Hi, everyone. Welcome to the Eczema Warrior podcast. I am super excited today because we have a very special guest. She is a registered dietitian and certified gastrointestinal nutritionist based in Phoenix, Arizona. She specializes in helping individuals with IBS, SIBO, and other digestive issues find lasting relief through natural solutions, all while enjoying the foods they love. With advanced training in integrative and functional nutrition, Alyssa focuses on uncovering the root causes of digestive problems and providing long-term solutions that enable clients to return to a healthy, varied diet without prolonged restrictions. Alyssa has successfully helped hundreds of clients finding lasting relief even after struggling to get results from multiple doctors. Her approach goes beyond quick fixes or band-aids, aiming for sustainable health improvements. She also educates and supports the public through her own podcast, The Gut Health Dialogues. She's also featured in prominent publications like Forbes, Medical News Today, and Everyday Health, among many others. Alyssa is recognized as a leading authority in digestive health. Alyssa, welcome to the show. I'm super excited.
Thank you. Yeah, I'm so excited to be here.
Amazing. I am very excited because today we're going to be talking all about SIBO, which is something that I see a little bit in my practice, but I'm sure since your practice focuses specifically on digestive health, you probably see a lot of SIBO cases.
Yeah, absolutely. I kind of learned that as I went along. I certainly didn't get into digestive health thinking I would end up specializing in SIBO. I didn't even know what it was, honestly. But what I found is that the referrals I was getting was a lot of the people that kind of the gastroenterologists were throwing up their hands and saying, okay, we've done the scopings, we've done the colonoscopy, we've done the endoscopy, we've done the CT scans, we've done the blood tests. They don't have celiac, but they're still having these chronic, sometimes really debilitating symptoms. And so they're kind of, I don't know, is it a food allergy? What's going on? And so I learned just by trying to explore solutions for my clients. A lot of times it'll just be called IBS because they can't find anything structurally wrong. And those are the people that I think, okay, test them for SIBO because a lot of times that's what's going on. And so a lot of times it's something that's just being missed because one thing that standard medicine does not look at is the microbiome. And the caveat is they're starting to test for SIBO more now, which is awesome. But it's still not the first thing they think about. People can suffer for years before they're actually tested, if they're tested at all. And then we'll talk about this more today. If the provider tests them, a lot of times they're not experts in SIBO. So the standard treatment is one particular antibiotic called rifaximin. It's very expensive. And that's it. There are a few different problems with approaching SIBO that way, which we can get into later.
I have so many questions already. There's just so many causes and symptoms and treatments, different types of SIBO as well. I'm sure, Alyssa, you'll be sharing a lot of that as well. So for our audience, could you just explain what SIBO is?
Yeah, SIBO stands for small intestinal bacterial overgrowth. And this is a big deal because we're not supposed to house bacteria in the small intestine. We're supposed to house our microbiome, which is all of our good bacteria, our probiotics bacteria, are in the large intestine. The large intestine has this thick mucosal barrier that's kind of like housing. Think of it almost like insulation in a ceiling. And that's where our microbiome lives. That's where a lot of digestion happens. And the small intestine does not have that robust barrier. That barrier also houses most of the immune system. So that barrier in the large intestine, the small intestine doesn't have that going on. The small intestine is mostly for, early digestion and absorption, but it's not supposed to house a lot of bacteria. So when we get bacterial overgrowth in that area, it causes tremendous inflammation and it interferes with digestion. And worst of all, for the patient and how they feel, what you have is bacteria feeding on food in an early stage of digestion, which normally doesn't happen because normally carbohydrates, which your bacteria love, are broken down into their building blocks, absorbed in the small intestine. So they don't end up, sugars, carbohydrates, they don't end up in the large intestine where they would meet bacteria and be eaten bacteria and have fermentation cause gas production. So none of that is supposed to happen, but that's what happens when carbs and sugars meet bacteria in the small intestine, and they have this heyday. The bacteria eat the carbs, they produce gas. The hallmark symptom of SIBO is bloating. Tremendous bloating is what we can see where the person looks pregnant. And I hear it every week. Someone saying, I look pregnant when
What
they
too?
first come to me. Yeah. And if they've shown you pictures, you're like, wow, yeah, it starts like right. Sometimes everyone's different, but it can start right at the rib cage and just go out like pregnancy. And that's really can be really painful as well. So yeah, it's a big problem. Did you want me to talk about the types?
Yeah, if you can explain the different types of SIBO, because there's three, right, to my understanding.
There are three types. What differentiates them is the type of bacteria that are involved, or the type of microorganisms, I should say, that are involved, therefore the type of gas that's produced, the symptoms we get, and therefore the treatment as well that we use. So the three types are broken down. We actually classify them by the gas that's produced because that's how we test for it. So we have hydrogen type, we have methane type, and we have hydrogen sulfide. The way to test for SIBO, the best way we have is a breath test. And because there's no scope that's going to get all the way through the small intestine. The small intestine, if you lay it out, it's as long as a tennis court. We can't access it to get a good read on what's going on, especially microbially. So the breath test, the way that it works is you drink a sugar solution. I like lactulose because it doesn't absorb. Some providers, others prefer glucose, but a lot of us like lactulose. So the idea is you want the sugar to go through the whole intestine, which for normal transit, and of course, a lot of people with SIBO don't have normal transit. So we keep that in mind when we're interpreting the test results. But normal transit, you can expect the sugar solution to take about 2 hours to go through the small intestine and 1 hour to go through the large intestine. That's why we like lactulose, because glucose will be absorbed pretty early on in the small intestine. And what we want is the sugar to feed bacteria throughout and produce gases so we can see where the bacteria is. So that's how the breath test works. So you drink the lactulose solution and then you collect breath samples over the next 3 hours. So that's how we test for it. And then we're able to see, do you have elevated hydrogen levels? Are they in the small intestine? Do you have elevated methane levels? And depending on the test, one test now directly measures hydrogen sulfide. Those of us who are experienced in SIBO, we can read a hydrogen methane test and interpret if hydrogen sulfide, many times if hydrogen sulfide is at play through some of the nuances of reading the test. And this is why I always tell people, if it's possible, we like to see a test result. Because a lot of patients too, their doctor's office will call them and say, you are positive for SIBO. Well, that doesn't tell us very much. So you were positive, what type was it? How high was the rated? Because if you have extremely high elevation, one round of antibiotics is not going to do it for you. I'm not saying we should do multiple rounds of antibiotics either, because there are downsides to that too, but we need a more comprehensive protocol. We can use herbal antimicrobials that really kind of target those organisms. We want to also then make sure we're supporting the whole gut, the beneficial bacteria and all of that. We want to know what we're dealing with. Can we knock this out in one round, or do we need a more robust protocol? How high are the gas levels? And also the type of gas tells us what treatments we need to use. So if it's hydrogen type, we're going to use these antibiotics or these antimicrobials. If it's methane, it's different. Same with if it's hydrogen sulfide, completely different protocol. So if someone tells me, yeah, I was positive for SIBO, I took the antibiotic, it didn't do anything, I'm not surprised, because that happens more often than not. I would say for 2/3 of people, that one antibiotic's not going to do it. And those are the reasons why. So rifaximin, which is the antibiotic they'll usually prescribe, same as Xifaxan, it's the same thing, that will only target hydrogen SIBO. It won't target methane. So it wouldn't do anything in that case. On the other hand, if you have hydrogen, but your levels are sky high, that one round isn't going to get it all. So you might see some improvement, but maybe not all the way, or maybe you'll see improvement, but a few weeks later, the symptoms just come right back because it grows back.
So when your patients come to you and they already have a SIBO result from their doctor, does it usually tell you like what type of SIBO they have? Or sometimes you have to actually go back to the doctor and ask him to show that in the result what type of SIBO they have?
It depends. There are a few different labs and a few different ways I've seen it done. But basically, I want to see the numbers, the gas readings, the parts per million, and the different gases. So regardless of how it's presented, if I can see that information. But what I don't want to see is just like a positive, negative, because that's what doesn't really tell us very much.
Do you find that the lateral breath test, or I mean, that's the main test people use to diagnose SIBO, is it quite accurate? Because I know that sometimes it can possibly create false negatives. Do you ever see that happen before in testing?
Yeah, so some of those have to do with nuances of reading the test. I mentioned earlier, motility can be a moving target. So in a perfect world, we expect that 90 to 120-minute mark to be, or 0 to 120 minutes. That's the small intestine. That's where we're looking for overgrowth. But if you have somebody with slow motility, so a constipation predominant person, which is a lot of people, then you're going to see readings farther along that look like they're in the large intestine, but they're actually still in the small intestine, and vice versa too. Somebody with fast motility. So if somebody has just diarrhea and everything's just going through really quickly, then we might see, I always get confused about the direction here, but we might see higher levels in what we think is the small intestine, but it could be the solutions already in the large intestine. Because we expect that last hour, if with normal motility, we expect to then see gases start to be produced, because that's where your large intestinal microbiome is. So if the solution's going through more quickly than 3 hours and it's already in the large intestine, we're reading the graph thinking, okay, this is only the 60 or 90-minute mark. It should be in the small intestine. We could be wrong. So those are things that you really need a skilled practitioner to take this into account, to read the test. So I had a person recently in the last few weeks, she has extremely chronic constipation, severe, and she had a flat line. What we actually saw too was we saw a flat line even in the large intestine. And I know that's not true. I know she has, so in what looked like the large intestine, I should say in the last hour, the 150 and 180-minute mark, we saw a flat line, meaning no gas being produced. So that's because her motility is so slow that the solution was still in her small intestine. It was not actually in her large intestine. Another reason that we can see what looks like a false negative, I mentioned earlier that skilled practitioners can read a hydrogen sulfide test, even with hydrogen and methane. Let's take the example I just gave, which is somebody with severe chronic constipation. Let's put that aside. Let's say we have somebody with diarrhea and we see a flatline result. So now we know there's either normal transit or fast transit. So it's not that the solution's still in the small intestine. When we see a flatline result, the kicker is the 3rd hour. You should see fermentation in the 3rd hour because that's your large intestine. If you don't, that's a clue that they could have hydrogen sulfide SIBO, because the hydrogen sulfide producing bacteria eat up the hydrogen that's actually being produced by the microbiome bacteria. They eat it up to produce hydrogen sulfide gas. So we see a flat line. So we need to pair that test result with the clinical picture. Do their symptoms line up with hydrogen sulfide SIBO? There are some distinct symptoms that occur in hydrogen sulfide that we don't see so much with the other types. And then we can also do a little trial. We could say, let me try you a week or two on a low sulfur diet versus maybe a low FODMAP diet or some of the other diets people will think of first. Because these are nuances with the test results, usually I will not just take the test. I'll look at the clinical picture. I might do a sulfur reduction in the diet just to get kind of more comprehensive confirmation that this is what we're dealing with.
For those of you listening, this is why it's so important to test everything. It can get very complicated. It's like you got to really look at the whole picture before we start creating a treatment plan. That's kind of what it sounds like for SIBO too.
Yeah, absolutely. The take home is it's a nuanced situation. You do want to find a practitioner. If you think you have SIBO, find someone who's experienced. Just keep advocating for yourself. Try to find somebody who's a little more focused on SIBO as their specialty, because that's not an uncommon situation.
Yeah, there's always a solution to symptoms. So you talked a lot about like some common symptoms of SIBO. I know you mentioned like bloating is one of the most telltale signs of SIBO. What are some other symptoms that people can start looking out for and suspecting if they have SIBO? Maybe for people who haven't done the test yet, for example, and they're suspecting that they may have it.
Yeah, so the symptoms of lots of different gastrointestinal conditions are annoyingly similar. There's a lot of crossover, but I'll tell you which ones are kind of similar across the board and then which ones kind of distinguish between the different types. We are also generalizing here because there's more than one thing going on with any person, as we touched on earlier. So sometimes we see exceptions to these rules. But the general symptoms of SIBO are bloating, gas production, which can also mean abdominal pain or discomfort, and then stool changes. And those are kind of the typical IBS symptoms. We can also see symptoms outside the digestive tract like fatigue, brain fog is pretty common. And then what can differentiate is the bowel changes we see. So in general, hydrogen type is going to be associated with loose stools or diarrhea or urgency to have a bowel movement, lots of frequent trips to the bathroom. In general, methane SIBO is going to be associated with constipation, slow motility, and along with that, we see upper GI slow motility issues. So we see a lot of GERD and reflux and nausea along with it. Because think about it, if your large intestine is slow, that's backing up everything on the conveyor belt. And even the methane gas that's being overproduced is what slows motility. So it's not just slowing the large intestine, it's slowing the small intestine and it's slowing the stomach emptying. And that's why we see GERD and nausea a lot of times with the methane type. If you have chronic constipation or chronic GERD, I would definitely have some alarm bells go off about potential methane SIBO. I mentioned that hydrogen sulfide has some really distinct symptoms. In general, hydrogen sulfide tends to be, and this is more just kind of a clinical observation, the sickest type, where people are just absolutely miserable a lot of times, just kind of all over. We could see diarrhea or constipation, and that depends on where the hydrogen sulfide producing organisms are, if they're in the small intestine versus the large intestine. So we can see it go either way. We see the, abdominal pain, gas and bloating, fatigue. We see joint pain. We can see dizziness, lightheadedness, headaches, tingling and numbness in the extremities. We can see like bladder pain or frequent UTIs can sometimes be associated with it. Some clues can be if you're sensitive to sulfur foods. So like sulfites are in wine. Sulfites are in onion and garlic, which gets a little confusing because onion and garlic are high FODMAP. So they're triggers for lots of people with IBS, even aside from hydrogen sulfide. But cruciferous vegetables are high in sulfur. Proteins high in sulfur, amino acids that contribute to sulfur. Dried fruits, wine, beer, if those are triggers for you, if cruciferous vegetables are triggers for you, and you have some of these other symptoms, those would be other clues.
Would they notice right away when you eat these foods? Like almost instantly they get this bloating and symptoms, or it can take a little while?
It can take a little while. It can be right away or it can be delayed. It depends because, typical transit time of food going through the intestine is 12 to 24 hours. So, if the overgrowth is early on in the intestine, you could start to see symptoms right away. And then it also depends what kind of symptoms we're talking about. If it's gastrointestinal, we'll see those symptoms, as the bacteria starts fermenting. But if it's other parts of the body, that can be a little delayed because it's related to inflammation, which occurs maybe even a day or two later after the fact.
Yeah, for eczema, it's kind of the similar thing. It takes a few days sometimes for a real flare up to happen. And then usually like something in the gut flares first and then the skin afterwards. A question I have regarding root causes. So SIBO can be a root cause for a lot of people, right? Why they develop these symptoms. But are there other root causes that can promote the development of SIBO that you see in your practice?
Yeah, so we need to talk about the root cause because this is another shortcoming of the standard way that SIBO is approached, which is here's your antibiotic, you should be good now, or you won't be. Doesn't work for everyone. That's kind of what they say. But what they almost never do in the standard approach is think about what, and this is true beyond SIBO, this is for all kinds of conditions with our medical system, is they don't think about what's the root cause. So we need to talk about the root cause with SIBO because if it's not addressed, the SIBO will just come back. over and over again, and it'll just be a chronic thing. The main reason SIBO occurs, it's not because you ate too much sugar. It's not because you have a poor quality diet. Those things can contribute to its overgrowth, but it has to do with the small intestine not being able to clear itself. We have a mechanism that happens in between meals. It's called the migrating motor complex. It's different from peristalsis. Peristalsis is a churning motion that the stomach does as it's digesting food. Then about 45 minutes to an hour and a half after we've finished digesting our food and we're in a fasting state, this migrating motor complex is a muscular wave that goes through the smooth muscle of the intestine, and it clears food and bacteria through and out of the small intestine. So I'm mentioning this because we can have things that interfere with this motility, and that is at the root of most SIBO cases. And the most common cause of this is food poisoning. I have a patient, Trevor. He did an episode on my podcast. I mentioned him in my masterclass. He had food poisoning when he first got married. I didn't even know that till we'd been working together for a while. He just thought that he had grown up eating a healthy diet. He got married. His wife wasn't a healthy eater. So he thought eating all the junk food caused these chronic GI issues. He barely remembered about the food poisoning till I asked. And then he lives 20 years with these chronic GI issues, and we finally found out it was, textbook hydrogen producing bacterial overgrowth, and we were able to resolve his issues and get him healthy for the first time in 20 years. As I was talking through him, I do this with all of my clients about what the root cause was. We identified a couple of different things, but it was all triggered with that. He remembered, yeah, actually, I had horrible food poisoning on this one episode and when we first got married. And what happens with food poisoning is there's the type of bacteria, there are a few different kinds that are involved in food poisoning. They have a toxin that our immune system develops an antibody to. There's a cell in our small intestine called a vinculin cell that our immune system thinks that it's this food poisoning toxin. It's an autoimmune, it's a mistake by the immune system. The immune system mistaking our own cells for something that's an invader. Then we develop these anti-vinculin antibodies. Our immune system thinks it's attacking the food poisoning toxin. It's attacking our small intestinal cells, and it makes it harder for our small intestine to clear itself. So that's why part of our process is supporting small intestinal clearing, and that's what we do with certain meal timing techniques and some supplements to help with that motility of the small intestine in people who have that going on. Other root causes, I'm just going to go down the list, but they have something to do with affecting the small intestine's ability to clear itself. So it could be vagus nerve dysfunction. That means that our gut-brain connection is interfered with, which happens with chronic stress.
Big one.
It's a huge one. Diabetes and hypothyroidism, those are two things that can slow gut motility. And especially in the case of diabetes, then we have high blood sugar, which is feeding bacteria, opioids and anticholinergic medications. Okay, adhesions. This is a big one. So how many people, especially women, have C-sections? How many people have hysterectomies, appendix removal, or people with endometriosis? So any sort of issue like that in the abdomen, so any surgery, or if you have endometriosis, you can end up with scar tissue that causes adhesion. So it's just touching, kind of adhering to the intestine. And so maybe where the intestine would normally be smooth, now it has little kinks and corners in it. And that can allow bacteria to build up. So that is a big one that I see actually quite often. And so I ask all my clients, have you had, oh yeah, I had a C-section 20 years ago. I've had a hysterectomy. And, they just don't necessarily think about that being related because it can happen over years that you start to have these issues. So in that case, there are different modalities. There's visceral manipulation, which is non-invasive. A specially trained practitioner can kind of work on you manually to help work out those areas where there might be adhesion. So that's what I usually recommend for that. Other medications that can cause or contribute, proton pump inhibitors. Those are the acid reducing medications we see a lot. And our stomach acid serves many purposes, but one of the purposes is to kill bacteria. We swallow a lot of bacteria throughout the day that's in our mouths and on food and things like that. And so if we're not killing it with stomach acid, it can start to populate the small intestine. Antibiotics, anything that disrupts our large intestinal microbiome can kind of wipe out enough of the good bacteria that it allows opportunity for weeds to overgrow, weeds meaning less favorable bacteria. And if those are overgrown in the large intestine, then there's the opportunity for them to overgrow into the small intestine. I think, though, typically that would be, you would still have something interfering with the small intestine's ability to clear itself. But that could be usually, if you have that paired with, lots of antibiotics, you'll see kind of a perfect storm happen.
Do you find that with slow motility, right? Some of these patients
Hmm.
are unable to clear their bowel. What about the patients with SIBO that are diarrhea prone because they don't have slow transit? So does that also apply too?
We can't always associate the symptom with the transit time. Diarrhea has to do more with transit time in the large intestine. You can have slow clearing in the small intestine and still see diarrhea because it's moving through the large intestine too quickly. So we do see those paired together. But yeah, people will be confused all the time about that. It is very confusing. So, for example, we'll choose supplements that stimulate small intestinal motility, and a lot of people with diarrhea will be nervous to take those because the types of things that stimulate small intestinal motility, and I'm talking about prokinetic agents like, ginger, artichoke, or some natural ones. There are prescription versions as well, like Botegridy is one of them. Those stimulate stomach emptying and small intestinal motility, which is what we're interested in with SIBO, but they're not going to stimulate large intestinal motility like a laxative or like a magnesium oxide. So it is two different things. Very confusing though, especially when you give someone with diarrhea a supplement that's called something like motility activator. And they're like, what are you doing to me? But it's different. Yeah.
That makes sense. I'm sure my
Yeah.
audience would appreciate that explanation too, because I would be
Yeah.
confused. Like, wait, what?
Uh-huh.
That makes
Yeah.
sense.
Yeah.
Okay, I would love to talk about diet. I know you kind of touched a little bit about it, but how does diet contribute to SIBO and what kind of recommendations do you usually give depending on the type of SIBO too?
So this answer is going to be annoying. It's all individual, but we do have frameworks and starting points that are very, very effective in most cases. And then you take that and individualize it. So we do have ways to calm things down quickly. And that really is the purpose of diet. So this is one really common misconception that if you have SIBO, you have to be on a SIBO diet, and that's like the end all be all. That's such a misconception. SIBO diet in that case would be some form of low sugar, low carb, low residue, or maybe low FODMAP diet. Some way to starve the bacteria. I listed those because there are different versions of SIBO diets, but they're all trying to not feed the bacteria. And the helpful part about that is in the moment, you're not going to get as many symptoms. So if we're not feeding the bacteria, they're not producing gas today and bloating me today and tomorrow. So in the short term, the diet is a means of controlling symptoms, which is huge because people are miserable with SIBO. So if we can control symptoms, that's amazing. And that's how a lot of people can get stuck in these restrictive diets because you see symptom relief. It's like this miracle because a lot of these people have suffered with no answers for so long. And now you finally feel better. You're not going to stray from that diet for anything, but it's not killing off the bacterial overgrowth. It would take, I mean, we don't have clinical studies on this, but I think I heard Seebecker, who's a SIBO expert, once say it would take, and don't quote me on this, but years to starve the bacteria. We're not going to starve the patient to starve the bacteria. So the diet is not the treatment, but it is a really good way to control the symptoms and long term to kind of help. If you're prone to SIBO, we clear the SIBO, we get a maintenance plan in place to address the root causes as best we can to prevent a relapse, not drinking large amounts of sugary beverages, eating high refined carbs diets. Those can be good as a maintenance strategy too. The different types of diets. Yeah, you'll see low residue. That one's kind of promoted a lot by Mark Pimentel, who's like the top SIBO researcher at Cedars-Sinai. There's the low FODMAP is used quite a bit. That's usually where I'll start because, dietitians and even naturopaths, we're more about nutrition and healthier diets, whereas low residue is a lot of just kind of junk white food and refined carbs, low levels of, but like white rice, white bread. So I'm more favorable to the low FODMAP diet. We see decent result with these different styles of eating. We also personalize it to the patient. I look first at how does this person normally eat and what's going to be the easiest next step for them. If they like a lot of healthy foods, they're probably going to do better with the low FODMAP than the low residue. But if they're like a, burger and french fries person, maybe the low residue will be easier for them as their starting point, and then we individualize it from there. And even then, I tell them, this is what we're doing for now to keep you comfortable while we're working through clearing the overgrowth. And then we're going to reintroduce foods and build your diet back out to be as varied as possible. Because once we clear the overgrowth, people go back to tolerating those foods that were feeding the bacteria and causing symptoms when the overgrowth was there.
Okay, this is a really important message for people listening because I know a lot of times people will go on these kind of diets to heal their SIBO and they never come off of it. So what
Mhm.
we're trying to say here is it's important to trial the diet as it helps to mitigate the symptoms, right? But at the same time, you need to be addressing the root cause and having an actual treatment protocol because the diet helps with the symptoms, but it doesn't help kill off the SIBO. Similarly to Candida protocols, I don't like it when people just go on a diet and say, oh, just go on an anti-Candida diet and your symptoms will heal. That hardly ever happens. There needs to be something to get rid of the Candida, and we need to start adding back the foods slowly while you're having a treatment plan, whether it's antimicrobials or herbal supplements to address it. Some people get on these diets and they don't ever come off of it, and that becomes a different issue, right?
Yeah, and then we see nutrient deficiencies. When you're not feeding the bacteria in the small intestine, you're also not feeding the good bacteria in your large intestine. So we see the microbiome become depleted, which leaves more room for less favorable to overgrowth. It actually, long term, to stay on these restrictive diets makes the problem worse in that
Worse.
sense. Makes your microbiome weaker, less resilient, more vulnerable to other things overgrowing or taking hold, and things can just keep snowballing. So I know it's tempting when you start to feel better to stay in that place, but now that you know it's not going to kill the overgrowth, you would need to take some additional steps to fully address it.
Right. So a common thing that I hear, and I think you mentioned this a little bit earlier, is that there is confusion between IBS and SIBO, and
Mhm.
SIBO is often misdiagnosed as IBS. So can you explain a little bit more about this, and if you've seen that a lot with your patients?
IBS anyway is a diagnosis of exclusion where there's no structural issues, the blood work's not off, the scans look normal, the scopes look normal. So it's a diagnosis based on symptoms description. That's, I think, where the misdiagnosis and SIBO is gaining knowledge and information about it still. It's kind of a newer thing. So I think a lot of cases that have been SIBO all along, the provider just didn't know about SIBO and was calling it IBS because it met the diagnostic criteria symptom wise. And I think a lot of chronic cases of IBS are actually have been SIBO all along. The studies show 60 to 80% of people with IBS have SIBO. A
Which
lot
is
of them don't know
significant.
it. And that's why I love talking about it, because for anyone listening, if you've had IBS and you're just like, yeah, this has just been told this is just how it is, you might have SIBO, and in that case, it's treatable, and you can go back to, not having these chronic symptoms and living normally and healing your gut and eating a normal diet again and not having to deal with all the things that come along with it. So that's where a lot of the mixed diagnosis is, I think, is just that people haven't known that SIBO is a thing. There are other causes of IBS, so 60 to 80% of SIBO leaves, 20 to 40% of other causes of IBS. So IBS can also be large intestinal imbalance. So you could have no bacterial overgrowth in the small intestine, MMC's working fine, but you have low, like a imbalance of good to not good bacteria in the large intestine. That can cause similar symptoms, IBS-like symptoms. It could be not enough pancreatic enzyme production, so maybe we're not digesting fats well, and that can cause IBS-like symptoms. So there are other things that can cause IBS other than SIBO, but SIBO's the big one. And if someone comes to me, which happens all the time, every week, that has these symptoms and has never been tested for SIBO, I definitely throw that test in there to make sure we're not missing something.
Right. Again, super important to have a full assessment. So I would love to hear your thoughts about the gut and skin and how SIBO, or I don't know if you've seen in your practice with many SIBO patients that have eczema and how that could be related.
Yeah, so I do see it in practice, and it is related through the gut, through the leaky gut connection. So the SIBO causes, because of the bacterial overgrowth in the small intestine, causes inflammation, which breaks down that barrier between the gut and the bloodstream. It's actually just a single cell layer that separates the contents of the gut from the bloodstream. And with inflammation, those cells can pull apart, and then endotoxins and inflammatory molecules get into anything that's in the gut. Small pieces of food, microbes get into the bloodstream, and that can trigger or worsen inflammatory skin issues like eczema. So there's the leaky gut inflammation component. There's also the nutrient deficiencies. And you and I talked a lot about all this on my podcast, the Gut Health Dialogues, when you were a guest with me last week. But SIBO, it also causes nutrient malabsorption because so many of our nutrients are absorbed in the small intestine normally. So that inflammation causes malabsorption, and it can cause us to malabsorb fat soluble vitamins like A, D, E, and K, as well as zinc and biotin. And those are important nutrients for healthy skin.
Right. Addressing the gut is very key here, healing the
Hmm.
gut. Yeah. So to wrap up the episode, Alyssa, is there like a number one tip that you would like to share to my audience for those who have been listening and suspect that they have SIBO or maybe they have IBS and they're really like, wow, I have all the symptoms that Alyssa shared today. What would you recommend?
I definitely think you should go be tested for SIBO if you're
Yeah.
having these symptoms. That's going to be number one. In the meantime, because it could take 2 or 3 weeks to get, I mean, if you can get into your gastroenterologist, I know here it's months for people to get into the gastroenterologist. So try to get a test. In the meantime, start on one of the plans. One of the gifts I have for your listeners today is a 7-day SIBO meal plan. I'll provide you
Amazing.
with that link that you can put in the show notes. Start with a meal plan and see if it helps. That's another clue too. It's not diagnostic by any means, but see if it helps your symptoms. And that can be just another clue. And then if you're looking for somebody to help you, our team, we do nutrition and lifestyle coaching for people with IBS and SIBO and other stomach issues. So we can also help. You can go to our website at nutritionresolution.com and schedule a free 15-minute consultation with me. I'll talk through your symptoms and what you're dealing with, and we can tell you if we can help you and what working together would look like on that. We do testing, we do gut testing, SIBO testing. If we feel like you need stool testing, there's some other things we do on a case-by-case basis to help get the full picture of what's going on so that we can really create a personalized plan to get you feeling better, get you back to eating a varied diet, back to living your life and leaving the house and not being tied to the bathroom and not being embarrassed about gas or belching or all those things that come along with it.
Yeah, that's what we're here for, to help our clients get to the root cause and start healing those symptoms that seem impossible to heal. But obviously from our conversation today, it's all the symptoms, SIBO can be healed with the right treatment plan and the right protocol. So thank you so much for sharing your wealth of knowledge around this topic. All of the links will be in the show notes so we can find you on your website and your Instagram as well, right? Which is
It's at Nutrition Resolution.
perfect. Okay. That'll be in the show notes as well. So if anyone wants to learn more about Alyssa, you want to work with her, if you think you have SIBO and other stomach issues, you can reach out to her on Instagram or on her website. And that's it for today's show. Thank you so much, Alyssa, again for coming on the show.
I thought it was great to chat with you, and we'll be in touch.